Hello, everybody. Thank you for inviting me to come here. So I want to talk to you about bone fractures. And when we're talking today, so what I'm going to do is I'm going to go over basic idea initially about what bone fractures are. You'll see two different kinds of bones, basically. One, how it looks in the spine, it looks like this trabecular, like lattice-like structure. And in the long bones, it almost looks like an onion peel. Like in the shaft of the bones, it looks like an onion peel. So those are the two basic concepts that you want to know. And so we're going to start with the spine. And if there's fracture in the spine, it's called vertebral fractures. And the vertebral fractures are the most common fractures. And why is it most common? Because when it happens, you really don't know it's happening. It's often slow, it's progressive, and it can cause other fractures if you have it. If you have one fracture, you can have another fracture. And if you have it, it can cause other problems in the lung, and it can affect your sleep. So these are some things to look out for. So sometimes, like I said, most often the vertebral fractures are slow. They're often asymptomatic. You don't have any symptoms. But sometimes it can be acute. And if it's acute, you may have like very minor trauma even that's causing it. And this is particularly important for people who are on steroids. Patients who are taking steroids are more prone to vertebral fractures. But it can also happen with other patients who have Duchenne muscular dystrophy. So it can happen with even limited acute back pain. And the pain sometimes you hear, like when you're an adult, you say, oh, pain's going down to my leg. It's really rare in this scenario, but it can happen. But if it happens, that means there's a herniated disc also along with the process. But it's rare to see that in this case, but something to look out for also. But they can also, then after that, can have chronic pain. Sometimes they have pain in their neck, they have pain in the back, obviously. Some people can even complain of a chronic headache. So that's something to be looking out for. Now, there's going to be some difficulty subsequently with the vertebral fracture of having bending problems, or rotating problems, or reaching problems. So these are some of the things that would be important for the people we take care of, right? And so those are the things that would affect their daily life. And one thing we have to keep in mind is if there's a vertebral fracture, we don't look for it, it can affect the lung function. We already have situations where as we become non-ambulatory, there is more restrictive lung function, and in this case, that can also affect it. So that's why you want to look out for vertebral fractures. Now, this is just a thing, this is just for fun. If you come to tomorrow's lecture, I'll show the same slide, so it's nothing new. This is the different kinds of vertebral fractures you're going to have. One's a wedge fracture, there's a biconcave fracture, and a crush fracture. And as you can see, that there are different locations where it can happen. One is in the mid-thoracic area. They tend to be more wedge fractures, and they look literally like this, like a wedge, when you look at a chest X-ray. Okay? And if you look at, there's a biconcave fracture. It happens more where the lumbar and thoracic spines meet. And in the lower lumbar area, there's often a crush fracture. So those are the things you're going to look for. And so what is it you would do? What would you do, or what should you do? Right? You want to give the patients pain medications first. You want to give your family member pain medication initially. And you want to, it should gradually diminish. But if you want to do something acutely to diminish the pain, make them lie flat. Make their legs go in pretty much like a T angle, and that will help a little bit with the pain. And then you want to take them and get evaluated. Now, when you get them evaluated, you're going to they're going to first tell you that they have a fracture, right? And you're going to say, okay, that's thank you, and what do we do now? Do we continue to move them? Do we do things? The answer is you still should do continuing your daily activity. But you want to be a little bit more ginger about it. You want to continue with physical therapy. And the pain improves. As the pain improves, the activity will improve. So that makes sense, right? So, and how long does it take before the vertebral fracture often heals? It's about three months. So at least the pain will go down roughly in 3 months, but they will still continue to have chronic pain, but the acute pain will go down a little bit. So let's talk next about long bone fractures, right? These are the things that you were worried about when we're doing transfers. So when we're talking about transfers, we're going to start with the bones at the bottom of the leg, and then we'll talk about the top of the leg. The bottom of the leg, they're called tibia, and the tibial fractures you can have at different parts. It can be often in the mid-shaft or in the distal area. And it can come from a high trauma impact, or it can be even from low trauma. And so those are both things to be aware of when we're doing transfers. So those are things to look for. Sometimes when people are going in the transition phase and they're not able to like go fully stand, and you're not yet wheelchair bound completely, you can have your foot planted and your leg can twist. And that can cause a rotational injury, and that's rare, but it can happen, so something to look out for. And of course, we have patients who are having steroids, and when they have it, they can develop osteoporosis, and this can also lead to some risk for long bone fractures. But more often, long bone fractures happen in the femur and not in the tibia for osteoporosis. So what do you expect for when you're having fractures? So you're going to see pain, you're going to see local discoloration, you can see localized tenderness. So obviously it makes sense, right? If there's a fracture in the leg, it's going to hurt there, it's going to be tender there, it's going to look funny there, right? And you may even see some shortening of the leg, and there may be some rotation of the leg. Sometimes there's even a puncture wound or protrusion of the bone if it's really serious. And so what should we do, right? Initially, as family members or as caregivers, what we do is we try to minimize further injury, right? That makes sense. And we're going to immobilize the patient. We're not going to try to make them move around or stand, and minimize transfers as much as possible. Put ice on it, give them pain medication like Tylenol or ibuprofen. Then when you take them to the emergency room, that's what I would recommend. When you go to the emergency room, you have to make sure you tell them that the person you care for has muscular dystrophy, and that they're either on steroids or not on steroids, and they're having problems with ambulation or not. But that won't make a difference overall in the subsequent steps, but at least if you alert them, they're going to be more aware for these kind of changes. And they're going to first initially splint the patient, so don't be surprised if they splint the patient, and subsequently may or may not need surgery. So now we're going to talk about long bone fractures in the femur, and what we're going to talk about is there's different areas again. There's in the proximal area, mid-shaft area, and distal area in the long bone of the femur. The proximal part, I'm going to talk about it when I talk about hip fractures. So for now, I'm going to again focus just mainly on mid-shaft and distal. In the mid-shaft, it often happens with high trauma cases. And it can also happen in low trauma cases if one is on steroids or one has developed osteoporosis. But it's more rare. Now in pediatric patients, often you can see some more distal fractures, and this can be from high energy mechanisms. But you can also see it in osteoporotic patients. And in particular, this is of some comment that we'll talk about later in the future. But people, especially if they're immobilized and they're sitting in a wheelchair, they tend to have some more weaknesses over there. So that's what tends to happen. So it's something to be looking out for. Now, with mid-shaft fractures, again, it's going to be the same as the end distal fractures. There's going to be overlap in what you're going to look for. You're going to have pain, swelling, deformity. But the difference is going to be in the mid-shaft fracture, there's going to be shortening in the thigh. In the distal fracture, you're going to have in the femur and the knee. So there's going to be a difference. So if you think it's happening more farther close to the knee, obviously it makes sense, right? You're going to have pain at the knee. And in both cases, you're going to be unable to bear weight. And there will be, in the mid-shaft fracture, there will be extensive soft tissue injury. So you're going to see rashes over there. So that's something you can look out for. And often, if this does happen, it can even lead to significant loss of blood in the mid-shaft, but does not happen in the distal. So in the mid-shaft is the one you have to worry a little bit more about. And in both cases, I'd want you to check for blood flow. And if there's something happens, so just check the foot pulses, just to make sure it's okay. So these are all the information if you initially go to the emergency room, what you'd want to tell the ER doc. Now, when they go to the ER, they're going to do X-rays. And so they're going to do AP and lateral X-rays. So that's what you want to know for yourself as to what to order. If they didn't order it, make sure they order both. And sometimes they may, if it's a distal fracture, they may do a CAT scan or some arteriography. And so that's, again, if you see it, don't be surprised by it. The main thing here is, you want to stabilize the patient again, do pain relief, and immobilize hip and knee if it's a distal fracture. Mid-shaft, they're going to immobilize everything. So that's just something for you to be aware of, so you shouldn't be too surprised by that. And of course, go to the emergency room, go to your primary care doctor. Please don't try to manage this at home, okay? So you will likely get an orthopedics consult and possibly go for surgery, depending on how bad it is. Now let's talk about the hip fracture, right? When you talk about the hip fracture, you see this is the femoral neck, and then this is parts of the femur, the proximal femur, right? So you can have fracture at the femoral neck. You can have fractures at this part of the femur also, called the greater trochanter or trochanteric crest, intertrochanteric crest, and those are the things that we're going to talk about. So these femoral neck fractures can happen from falls, often from a twisting mechanism. Again, foot's planted and the body rotates, so this is one of the challenges when we're doing transfers. You can also have intertrochanteric falls here from falls, and trochanteric fractures from falls, or forceful muscle contraction. So you want to be just careful about stretching too hard as people become more contracted, and if they're particularly on steroids. You want to do your stretching, but just be a little careful. Now, what are the symptoms that you're going to look for, right? What's one of the main things that we all want to know? You're going to have, again, same thing as before. If it's broken, it's going to hurt there, right? Makes sense, right? So if it is at the femoral neck, you're going to have hip fractures, sudden at the hip pain, and you're going to have growing pain if it's a femoral neck fracture. And the leg will look like it's rotated and short. So if it's an intertrochanteric fracture over here, there's going to be hip pain again. There's going to be swelling and local bruising in the area. And the leg, again, will be rotated and shortened. Nothing new I'm saying so far, right? And lastly, the trochanteric fractures. So you have, again, same thing, hip pain, pain in the groin, sounding familiar, right? It's good, trying to repeat the same things. But there may be differences here. And if it is, you can have pain that goes to the knee or to the thigh, or there may be pain in bending. So in this case also, again, you got to get hip X-rays. And you got to have AP X-rays. So those are the things to note. Sometimes they may do MRIs, and that's what you do. And lastly, what is the management? It's again the same thing. So what I want you guys to know is don't try to do this by yourself, right? That's the first thing I want you to do. Just stabilize the patient. Don't really move the patient. Call somebody, like an ambulance service. Do pain relief because it's going to be hurting. Tylenol, ibuprofen, something that you have at home. They will give narcotics when the patient, when your loved one goes to the ER. They will give some opioids, and immobilize. They're going to do the same thing, and you're going to probably get a surgical evaluation. So those are the main things there, and that's what I have to say. I know I'm out of time, so I just want to make sure. Thank you for listening to me, and I hope I can answer any questions.